sure.
Yeah.
So. I didn't know somebody speaking was good.
Sort of looks like a beard when you take the mask.
Yeah.
Okay.
But being a woman of a certain age, I appreciate the chin cover. Or the neck cover.
Yes.
So once again, good morning. Welcome to Disabilities Awareness Talk. All you wanted to know about hospice, but were scared to ask, or maybe just nervous to ask. I want Bob Spaley to introduce our speaker. He is the member of Access team who offered to arrange for this morning's session. So Bob.
Great. Well, you might wonder what hospice has to do with access and disabilities. And the reality is that we all enter this life disabled. And the bulk of us are going to leave this life disabled. And hospice has a big role in the exit. And consequently, we have a representative from hospice this morning who knows just about everything there is to know about it. She's an advisor to the Arbor Hospice, as well as the rest of Michigan as well. So, Julie Capra, you're on.
Thank you so much. I'll take my mask down if that's okay.
Sure.
The group, since we're distanced, and we have plenty of time for questions and answers afterwards. If there is a burning question and you think you're going to forget, please feel free to just shout out your question during the presentation. But if you want to hold it until after, that's fine too. So I just want to say thank you to this beautiful community, and of course to Bob for inviting us to join. And a quick little bit about Arbor. We have been a community-based hospice organization here based in Ann Arbor. Our statewide organization is based here in Ann Arbor since 1984. And we are a mission-based, non-for-profit organization helping anybody, regardless of their diagnosis or ability to pay, and their age, by the way. We also do pediatric hospice, but we're not going to talk about that right now. We're just going to do a real general hospice fact fiction program. This is designed to be interactive. We encourage people to shout out answers. There's a couple of questions, sort of Jeopardy style. And, you know, it's a heavy subject, and we really want to try to demystify it, as this is healthcare. This isn't just, you know, that scary word. And we're working so hard to demystify the entire process. And I think that you'll find some of this information surprising and most definitely informative. And so here we go. Hospice itself is really not something to be scared. So if you want to move on to the second slide, thank you so much. Hospice pays special attention to enhancing the quality of life by making our patients as comfortable as possible. We aim to relieve physical, emotional, there's a typo, and spiritual suffering. This is what we call comfort care. And on the next slide, you're going to see an umbrella, and the umbrella is the word palliative, or the term palliative care. And palliative literally means to provide comfort. Underneath that palliative umbrella is a bunch of different types of care, and one of them is hospice. So when a lot of people think of that word, they think of giving up or the end of hope. And that is absolutely not true. We would like to change the mindset and the paradigm associated with the word hospice with presentations like this, and continuing discussions with your own friends and family as well. So we're going to move on to the next slide, and oh, it gives us the answer. Okay, that's not quite fair. Usually we can click on that. So this takes away a little bit of the surprise. Fact or fiction, care is provided by a team of professionals, and we're going to move on to the next slide there. That is a fact. You have a team, or what we call the interdisciplinary team, or the IDT. And at the top, you can see that's your hospice physician at the top. And then moving around, moving around that dial, you have your physician involved if you would like, and then your hospice physician, which is part of the interdisciplinary team, and then your nurse that comes to the home. Then you also have a social worker, your hospice aide, a chaplain, very important part of the team. And then I'm going to have to zoom in. Oh, your bereavement counselor, your volunteers, And then in the center, of course, is the patient and family. So all of these people surrounding that patient and family with care, it is most certainly not have an illness, so there's your physical body, and we're going to give you medication. That is absolutely not the beginning or the end of it at all. You have a team of people, and this is a Medicare benefit. Medicare covers 100% of hospice. So please know that all of these people are part of that team, and they are working daily on all of the patients that are served by any hospice organization. Arbor Hospice, of course, is one organization, and I believe last time I looked at my competitor list, there were about 130 organizations in the state of Michigan that call themselves hospice, and probably about 15 or so in the Ann Arbor area that are. So this team of professionals is really wonderful, and you can go to the next slide if you wouldn't mind. And here's the answer for you anyways. Fact or fiction, the care team only provides basic medical care. And of course, as we just illustrated in the previous slide, that is fiction. And you can move on to the next one. So we provide a comprehensive comfort care managed by the team, and that includes your physical care, control, pain control, symptom management, personal care, and then emotional and spiritual support, which are provided by everyone on the team, but most notably the social worker and the chaplain. Sometimes finding meaning, people that maybe haven't been part of a spiritual group such as this one, really need that support. And I cannot stress enough how much talk about the spiritual care aspect when facing a terminal illness. Or what I like to call a life-limiting illness. So many people that really need that spiritual piece more than they ever imagined. It's something perhaps that I see a lot here in Ann Arbor with a lot of agnostic folks, and they haven't really delved into the spiritual constructs. And this really is an important piece. And what I find incredibly fascinating is that, and I'm grateful, is that Medicare pays for that component. And really, this is the only form of healthcare that the spiritual pain is addressed and paid for by Medicare or any insurance. So it's a very big piece that I actually have a whole separate program for future reference is the spiritual aspect. But it is really important. Also very important to know that all of the medications associated with the primary diagnosis are covered under the hospice benefit, as well as equipment, basic equipment for limitations. So that is important to know as well, that they get a hospital bed and all sorts of items that are associated with the progression of their disease, the patient. So it is important and helpful for the patient and the family, of course. We also have trained volunteers, which is a very robust program here in Ann Arbor. So many families have been through our program with their own loved ones, volunteer their time out in this community, and I cannot express my gratitude enough. I myself am a volunteer as well as an employee, and I've gotten to know so many of our volunteers through this program. And I'm sure, as lots of you out there know, that form of giving back is such a deeply meaningful and helpful thing for all of us in so many ways. But our volunteers are vast. We have pet therapy volunteers, people that have their dogs bedded and then take them out and visit patients. Really a meaningful program and very therapeutic, especially who are isolated and are unable to have a pet in their own home if they're living in a communal setting. The pet therapy visits are really joyous. We also have volunteers that will just sit bedside and provide support by listening or by reading for somebody who can no longer read or see, or for playing music for somebody with dementia or another cognitive impairment. These therapies are beautiful and amazing. And we also do have professional music therapy, but the volunteer programming can be such a wonderful supplement and provide such great comfort. Some people sit vigil for a dying patient that doesn't have friends or family at all. Obviously, incredibly meaningful, and I'm going to tear up talking, so I'll just something that's out there. Yes.
Can I just, something that you all, I would need to brag a little about our congregation. I used to work at the inpatient unit where we had this by your side program.
Yes.
And I actually called Claire Dahl on a number of occasions, and she came and sat by somebody at the end of life who did not have family there. So that's a member of our congregation who's done that. So I just want to give a shout out for her.
And that program still does exist, by the way, so we can talk further about that another time. But we do have an inpatient unit. It has moved from Ann Arbor proper to the Saline area. We rent space from our friends at Evangelical Home. And we do have an inpatient unit. It's much smaller now. It's 11 beds, but we still do have it, and we still do have volunteers come to the facility and into the homes. The truth is that the majority of hospice patients choose to stay at home, you know, and not move to a facility. So that's where we see the lion's share of our patients is in their own homes, wherever that may be. So in addition, the 24/7 contact center is available to people inquiring about hospice, and anybody is welcome to call that number. Of course, now you know me, so I'm your local advisor. You can always call me directly, but you have access to the 888 number at any time, 24/7. And after 5 o'clock, whether it's a patient or somebody calling to inquire about service, it automatically switches over to our triage nurse. So you get a registered nurse on the phone after 5 p.m. until 8 o'clock in the morning. So that's good to know that if you do have a question that would require a medical professional, you could have that access 24/7. And of course, once again, you have a local resident expert here as well. Yes, I'm sorry.
A question, when you have a patient that's in a, like say, an assisted living situation, the hospice is coming in, but obviously the assisted living situation has caregivers of their own.
That's right.
So how does that work when the hospice caregivers?
That's a great question. Thank you so much. So to answer that.
Would you repeat the question, please?
Sure. So my question was, when you have a hospice patient that's not in the home, but are actually in an assisted living situation, and not in a hospice care unit, but actually in another situation that's not at home. So in the assisted living, you have caregivers that are already part of that facility. When they go on to hospice care, how does hospice caregivers coming into an assisted living, so how do they coordinate care? How do they?
Thank you.
It's an excellent question, and in fact, our next couple of slides address that, but
Okay.
we'll dive right in right now by saying that we will provide care anywhere a patient is. Whether it's in an assisted living, whether it's in an adult foster care, whether it's in a private home, a condo, apartment, no matter what their support level is, we come in, and if there is existing support, like hands-on support in an assisted living setting, we simply come in, we're the medical entity. We're not there 24/7 with hands-on. Unfortunately, Medicare does not support that, but we do come in as the medical entity and so much more. So we work in a complementary way. We're associated with them. We will follow whatever the building's rules are for communication. They're mandated to certain types of communication. So in an adult foster care, there's certain legal things that they have to do. Same thing with the nursing home, being a little bit more stringent because they are a skilled medical entity. And then of course, most assisted livings are licensed. So they have a licensure that they're practicing under, and they have a certain protocol, and we follow their rules because we are truly guests in their house. And we coordinate the care with their, whether it's director of nursing or their wellness director, whatever you call it in that particular facility. But that's an excellent question. And we do lots and lots of work with our community partners, we call them. So we'll move into the next slide. I can receive hospice care at home, and that is indeed a fact that the majority of our patients are in a home setting, whether that is, again, in an assisted living. They refer to that as their home. Okay, so and home looks like a lot of different things. So again, this is what perfect timing. You had a premonition. We come to our patients. We provide this care wherever patients call home. And again, most do live in their own private home, but we also care for people that live in a multitude of facilities like AFC homes, assisted livings, and even in hospitals. So that's a specialized inpatient care. That is not a widely used form of medicine, but in an event where a patient's pain or symptoms are not being managed by the hospital staff, they do call in hospice agencies that they're contracted with to come in and administer care for the patient. And that is a more rare thing.
Hospitals are limited in what they can provide, aren't they, in terms of pain care? And
Well-
hospice has
Yes,
more abilities.
that's
yeah.
right. That's right. And that goes across the board, not just for hospitals, but physicians in general are sometimes reluctant, and understandably so, especially with this, in the more recent years, there's been a lot of concerns around opioid medications.
Mhm.
And so physicians are rewarded for not prescribing these kinds of medications, right? A whole different our specialty of medicine. So that's not a concern for us. We do are comfortable and not in a place of suffering. So that's
Yeah.
a different concept completely. So we can go to the next slide. We're going to talk about the levels of care that are available in hospice. So 4 basic levels of care are routine care, which you can see on this slide. It's care provided by a caregiver at the patient's place of residence with assistance from the hospice team. And that person can also bring in supplemental care for hands-on care via private duty home care. Continuous care, that is a skilled nursing service. That is a very specialized form of care. And that is when a patient's care is not being managed inside the home or wherever they call home. And we will station a nurse and make sure that those symptoms are managed, and we will not leave until those symptoms are managed. And that again is not a really common scenario, but it is there and it does happen. And we do have to place staff in continuous care on occasion. So making sure that the symptoms are managed is paramount. Inpatient care is provided in a hospital or a nursing home setting for a limited time to control the physical symptoms that cannot be managed in the patient's home. So that is a form of care. I mentioned the term GIP or general inpatient, where a patient would be transported. In our instance, since we do have this wonderful residential care unit, if there is sometimes a severe symptomatic episode and we're not able to manage it, we normally are, but if we're not, we can put the patient on an ambulance and transport them to our inpatient unit and then transport them home once the patient is stable and the symptoms have been managed. But again, these are very specialized. And then we offer something called respite care, and I think Bob can speak to this. This is a wonderful service that can be provided in a nursing home setting up to 5 consecutive days. This can give family caregivers a break and also give the patient a break from their routine setting. And Medicare pays for that respite stay in a skilled nursing facility.
Yeah, I could add to that a little. We've taken advantage of it twice, and it's available apparently every so many weeks. You get 5 days and your caretaker gets a break, and you get a break from your caretaker.
That's right. That's right.
And we took advantage of it once in Saline, which is the hospice facility.
Mhm.
The second time was in, let's see, Traverse City. And we found just a assisted living. You don't have to have a hospice facility. Just
It was actually a skilled nursing facility. that
Skilled
had
nursing,
an assist- Yeah, it has to be a skilled licensed.
Exactly.
See, I wish it was assisted living that Medicare paid for, they don't.
Yeah.
So,
Well, it worked out just beautifully, and they give you all the freedom you need. I had an aide that had come with me, and we went off to visit. You know, we have a place up north, and so we had a lot of friends, and it was just a really good respite.
good. See that, hence the word respite. It gives everybody a break. So it's pretty terrific. And again, this is part of the Medicare benefit, and a lot of people really find it very helpful. During COVID, we have found a lot of challenges, unfortunately, and so we've had a lot of longer wait times. Sometimes facilities would have COVID outbreaks, and that we were able to facilitate those respite stays. But all in all, it's a wonderful thing that a lot of people just don't know about. It's one of those little secrets that shouldn't be a secret. It's really, really helpful. So we can move on to the next slide if we can. Fact or fiction? Only cancer patients go to hospice. That is, of course, fictional. That is not true. So you can move on to the next slide. As far as who can receive our care, any person facing advancing stages of a terminal illness is eligible for palliative or hospice care. And hospice care is appropriate when the following conditions are met. And I say quotation marks, see my quotation hands, because nobody's trajectory is exactly the same. And these are guidelines, and we have to have guidelines that are, of course, are mandated by Medicare, who we answer to, and major insurances. But in order to be admitted by hospice, this is the formal statement that a patient must be certified by 2 physicians to be terminally ill with 6 months or less to live if the illness runs its normal course, whatever that means. Okay, so there's a lot of gray in there. I have had patients be on service for years. I have not had patients be on service for hours, and sadly not even make it to the entire admission. So through the entire admission process. So we have such a vast world within this note here. Again, Medicare states that a person, according to a doctor, they have to certify that, yes, I believe that given the trajectory of their disease process, that I wouldn't be surprised, the doctor saying this, I wouldn't be surprised if a patient would not be here in 6 months. So again, there's so much movement within that. And of course, the patient must desire to follow a comfort care model as opposed to curative. So we would never sign on a patient that was not in line with the concept of comfort versus curative. And that is a big one.
Sorry to interrupt you. Excuse me. Do you feel, or have you seen that there's any reluctance on the part of skilled nursing facilities to recommend that a patient be placed in hospice care?
Really broad question, really good question. Skilled nursing facilities as an entity, no. Individuals within, absolutely. So it could be a medical director, the physician that is overseeing all the care in the building that has antiquated concepts of what hospice care is or palliative care is. Most physicians nowadays are, especially the newer ones coming up through school, have different ideas, and they actually, most of them from U of M round with us anyways as part of their palliative and hospice training. So we're so grateful for that because it's part of their schooling now, whereas some of the more mature physicians, age-wise, didn't have that training. And so it is definitely a conflict internally for some people, but skilled nursing facilities, no. In fact, a lot of skilled nursing facilities welcome the partnership and the collaborative effort in caring for somebody. The concept really is, again, if you want to keep going to the hospital over and over again, if you want to do what Bob and I coined the dance, going to the hospital, going to a skilled nursing facility, coming home. You're home for a while, then there's an event, and you go back to the hospital, you go to the skilled nursing facility, and then you come home. And it becomes this cycle. And sometimes we realize, wow, we're not really getting better. Things are maybe staying static or unfortunately going in the other direction. We as a culture, especially in the past, decades, we sort of normalized this as, well, that's just the way it goes. Whereas what we have found that people actually do better not being shuttled around. And if there is indeed a shift in the consciousness and you don't want to, or there are no more curative treatments that will be effective, it's, that whole risk and benefit, concept, and you look at it and you say, well, I'm not doing better. Going to the skilled nursing facility for some is as wonderful as they can be. If they're not really helping us progress, then we can have that shift in consciousness and say, you know what, I'd like to stay home and have my healthcare come to me. And especially during a pandemic, a lot of people have found that to be much more helpful. But a great question. And again, we could go on, and I won't, but we can take that offline and talk more about that. There are people that still screaming when they see the word hospice or see my badge. I've had physicians come to greet me and they look down and they see my badge and turn about face and walk the other way.
Oh,
And it's happened more than once. So there are people out there, not many anymore, but they are still out there. So again, that desire by the patient or the family, as you can see this last slide, or the slide that's currently up, that's everything right there. If the patient and the family are on board, and sometimes you'll have within a family a disagreement. A lot of times it's adult children, or a spouse that will say, well, no, we're not gonna, that's giving up. And again, it is not giving up. It is just shifting our plan because of the events that are taking place. So,
Sarah Newton has it. Yeah.
oh, there's a question. I'm so sorry. I'm half
No,
blind.
that's okay.
I was a hospice volunteer for about 2 years in the late, I can't remember exactly when, but 20 years ago or so. And I was very impressed with the training and had some, I don't know how to say it, but it was like a privilege to be able to be visiting the patients.
It's profound.
And also when my mom had a cardiac arrest and resuscitation, I brought my parents up here to Ann Arbor. And when mom, it looked like her cardiac situation was not going to be, it might be quickly terminal, I got her in hospice. Unfortunately, she didn't have any short-term memory. And when she got in a situation, she called 911. And then hospice didn't want her, or they told her she couldn't be in hospice because she was calling ambulance. So that was a tricky situation. So.
There are many like that. We see that a lot. It's very difficult. Now, we're going to get into a slide that touches on something that you just brought up. So we'll all hold that, but that's a very, very important issue that you talked about, 911. And we'll get to that in a moment. But what I do want to say while we're still on this slide is that there are, again, parameters for hospice eligibility and enrollment. If there's anybody that's interested in the Medicare parameters and wants to dive into that further offline, I'm available. I welcome anybody to, contact me to talk about that. Yes.
I just want to say that desire by patient or family, you might not get asked by a physician, are you ready for hospice? In the case of my mom, I had to bring hospice. It was almost like, I think physicians don't know who they're dealing with. Some families want to try every last treatment. And some families are okay with saying it's time to go to comfort care. So I just want to encourage people, don't wait for the doctor to tell you it's time.
Right.
I brought up the word hospice myself, and then they were like, yeah, let's go with that. So you may be the person who has to bring the word hospice into the conversation.
Yes, culturally, it is one of those, I make jokes all the time that hospice is really a 4-letter word. And in our culture and in many other cultures around the world, that is not the case. However, here we have a long way to go to demystify the word. And so again, I'm so grateful to be here and to talk about what I talk about every day. And again, thank you. So we will move on to the next slide then. Hospice pays for everything. Okay, well, that is a myth. We can move on to the next slide. Medicare, Medicaid, and most commercial insurances cover hospice. And again, I want to mention that Arbor Hospice will serve any eligible patient regardless of their ability to pay. Part of our non-for-profit mission is to make sure that everybody is served for hospice. So I am fiercely proud of that. Our mission and our foundation, the Arbor Foundation, where we raise these monies, we have different buckets that it goes into, and we, try to disperse appropriately. However, people can donate to the programs that are most meaningful for them. So for instance, it can go towards volunteer programming. If that volunteerism was so impactful to a family in a patient's life, it can go to the pet therapy program. It can go to grief support counseling. One of our main missions here in town that I am always talking about is our grief support. It is so much more robust than anything out there as far as the service that you get. Medicare pays hospice organizations for a phone call and a card, and that's it. That's what you get for grief support from the Medicare benefit. So why our service is so wonderful and robust is that we have grief support counseling. We have ongoing groups that are closed to 10 participants only, so everyone gets a moment at the table. Because of the pandemic, we switched to a platform like this one, where we were meeting exclusively on Zoom. That is opening up now, and we're doing our grief support groups, some of them in person again. So again, we offer these ongoing grief support groups. I cannot speak to the importance. We have a loss of parent, loss of spouse, loss of child. We collaborate with Ellie's Place here in Ann Arbor for those specialized children's groups, the pediatric groups. And we of course refer teens and children to their groups as well. But we have so many special lectures. We have events at libraries. We have a dining group. We have the dinner diners, and then we have the lunch bunch. And those are targeted, I think, a little bit more towards age. The working age group is usually the dinner diners. I don't know why, because we all eat regardless of our age at dinner time. But we have groups that get together, and these are less formal, and those are actually hosted by volunteers, special volunteers that are trained in grief support. And people can get together with others that are experiencing the same thing, and that's the grief over losing a loved one. And I can't speak enough to that, how important that is. And it's important for the patients. They can tap into the grief access when they need it, and the families can utilize these services forever. And I am incredibly proud of these robust programs, because these are things that are so very important. And then sadly, the Medicare benefit just doesn't touch the need. And so that's just one more reason why these groups like this, having access to, getting together and finding out about them, it's really spreading the word within the community. And I will say those are popular groups. And as soon as we post them on the internet, they're usually filled up, the ongoing grief support groups. So I always tell everybody, shop early and often for those. Please get yourself signed up. And anybody can sign up. It doesn't have to be somebody that was on hospice. Sometimes there's a sudden event and you find yourself at a loss and grieving. Those people are welcome too. We don't discriminate. They don't have to have been enrolled in hospice or even our hospice. They could have been coming from a competitor's hospice organization as well. All are welcome. So that I think covers that. Medicare and Medicaid and insurance is paid for our service, but a lot of what makes us special in this community is by generous donation and volunteer services. So
It's like Linda has a question.
yes.
Uh,
There's another. Thank you for pointing that out. Yes, question.
Go ahead. But is it true that Medicare does not pay for the inpatient hospice bed at EVH?
Okay, that's a great question. Yes. Room and board is separate from the hospice.
Right. Yes.
Medical service and again, the person, all the other things, the equipment and the medications, but the room and board at any skilled nursing facility is private pay.
Yes. Okay. And there are only 11 beds at EVH?
At the residence at Arbor Hospice, there are lots of beds at EVH. That's a separate, the residence at Arbor Hospice is an 11-bed specialty unit, and that is for last 30 or less.
Which is a lot less than you used to have on Oak Valley, right?
Not a long-term care solution. We have many, many, many partners out in the community that are long-term care beds, but our resident hospice is a specialty unit for patients 30 days or less.
Okay.
Also use it as a GI and send the patient back to home wherever that may be.
Okay.
Thank you. That's a really great question. I know that a lot, the residents of Arbor Hospice has quite a legacy in this community, and so yes, it did change to a different concept. And we work so much with our other partners like Evan They have lots and lots of long-term care beds in their facility.
Mhm.
And I mean, our census in that facility is quite large, and many others throughout the community. So thank you. That's a great question.
I have a specific question from the previous slide that I'd like to talk to you afterwards, or can call you at another time.
I'm here for you anytime.
Great. Right.
We can move on to the next one. This is a fact that anyone can call for a hospice consult, contrary to preconceived notions. Anyone can. So anyone can make, and you can click to the next slide. Anyone can make a referral to hospice. You know, some medical professionals or physicians do make that referral, but friends, family, neighbors, anyone can call, and there's absolutely no obligation to doing so. You can call to get information. If you want somebody to come out, if you feel that a loved one, let's say there is a neighbor and you're really concerned about them, you've seen their functional status changing over time. Maybe you notice that the mail is piling up, that they can't get in and out of the house, a disease process, or you're just worried, you can call us at any time. And if you're concerned about a loved one and you want to just get information, anybody is welcome. So it's not just a physician making that. You want to gather some basic information. If you are making an actual referral, the patient's name, address, phone number, date of birth, and it's 7 days a week. And there's that 800 number, and there it is. All right, we can move on to the next one. To have hospice, a person needs to be days or weeks from death. That, of course, is fiction, as you can see there. When to call hospice. So there's a lot of different things going on here, and not just one answer will often make somebody eligible, but oftentimes there is what I like to call a symphony of things happening. And so there's a process. And again, for a question, we do ask that you call, and ask anybody can call in. But if you know, you want to look for things like shortness of breath at rest, or if somebody is oxygen dependent for a pulmonary disease, that's a big one. If there's specific or significant weight loss, more than 10% over 6 months or less, decreased appetite, decline in cognitive abilities, increased pain levels, nausea and vomiting with inability to keep any food down, incontinence, which can come on suddenly or over time, unable to feed or dress, inability to ambulate without assistance, inability to communicate, lack of response to treatment, repeated trips to the hospital, resident or family desires comfort care only. Resident should be patient. A recent change to their DNR status, if somebody has made that change, then we can look into talking about hospice care if that's not already in their plan. Frequent or prolonged use of antibiotics actually can be an indicator that something is heading towards a hospice diagnosis. Recurring fever after use of antibiotics, difficulty with wounds healing. A physician states that there's no further treatment options. A person is retaining lots of fluid, escalating emotional or spiritual distress, and the patient states that they are preparing to die. Those are all indicators that hospice might be something to look at. Okay. Move on to the next slide. You have to have a DNR in order to enroll in hospice care, and that is, in the state of Michigan, fiction. That is false. A person can have not signed their DNR and be on hospice care. If somebody wants to remain a full code, that is their right in the state of Michigan. Most hospice patients do not look at the DNR as a negative. They are okay with it, but there are patients that say, I want to be a full code. I want to go in the ambulance. I want to go to the hospital. This is what I want to do. Now that's a whole nother conversation. And I am actually an advanced care planning facilitator. So I can speak, and I have a whole separate presentation that I do about advanced care planning and your medical wishes. So that is something that I'm going to dive into today, but if you would like to ever have me back, I would love to talk about that subject, and a DNR is a big part of that. Okay, folks. Full code, what that really looks like when somebody comes in with the crash cart and questions and paddles and all those other things that they do, The reality or the outcome is unfortunately very different typically than what we see on television and in the movies. If we have an advanced illness, if we are frail, if we have anything going on that is going to make us susceptible to being injured from those types of compressions, which is most of us after the age of 65, we really, and if we have an advanced illness, the outcomes can be pretty bad. I think that if you look at the general, anybody over 65 with an advanced illness, I think 8% of us will survive an intervention like that, okay? So, and then if we get really drilled down, the majority of hospice patients, it's 3% that will survive that intervention. And again, we have to realize too, if we're having a major event like a cardiac event, you know, we're having a major event. So there's oftentimes no turning back from that anyway. So it is a really, really hot topic, but a patient reserves the right and they do not have to enact their DNR if they are in hospice. So little known fact right there. So that's usually the one thing that people walk away with saying, I didn't know that. So we're going to move to advanced directives, and the advanced directives are, again, the DNR is part of your advanced directives, but your medical wishes are a really, really important thing. And if you all don't know what they are, please, you can find them for free on the internet on Making Choices Michigan and a few other websites. These are free downloadable documents. You can do them. You don't need an attorney. You do need a witness. So you might have to get a neighbor to sign them, but you can become very specific about how you want your medical plan to go if you are unable to speak for yourself. If there is an event, I just had a friend, very young, he had a stroke at 53 and was unable to speak, and his wife had to make all of his medical decisions, and she had no idea what his wishes were in an emergency, and they've been married for 20 years. So it's really a good idea to write down how we want things to go if we are unable to speak for ourselves. Are there any questions out there about that?
The name of that website again?
Making Choices Michigan, that's just one place that you can find an advanced directive form. And that's, you can fill it out and then print it out. Again, you do need some signatures on that, but you do not need an attorney for that advanced directive. That is something that you do. It's not like your will or anything like that. This is simply, and very importantly, your medical wishes and how you want things to go. I keep one in my car. I keep one in the freezer at my house, and I keep a note on the side, on a magnet on my refrigerator that says advanced directive and freezer in a tube. So that way, if something happens to me while I'm at home, the medics can find it. And if something happens to me in my car, then the medics can find it. And it's got it all boiled down, who my medical power of attorney is, the person that can speak for me if I'm unable to speak. My adult son has been given that duty. And then if he can't, or if he's in the car with me, then it's my daughter. So it's pretty simple stuff, and we'll move on from there because I don't want to run out of time. Oh, here's a really big topic. Hospice patients are on morphine, which makes you die faster. Folks, that is fiction. And I am here to tell you, morphine, or Roxanol, the form that we use morphine most frequently, which is a liquid form that is delivered inside the mouth or sublingually. It dissolves and it is absorbed into the bloodstream. And we use lots of medications, not just morphine or Roxanol. But Roxanol is not going to hasten death. It definitely can. It is a smooth muscle relaxer, so it is going to release the lungs if there is a breathing. This is something that we see all the time. If there's a breathing crisis and people become anxious, so that anxiety feeds the breathing problems, the breathing problem feeds the anxiety, and it's a loop, and we can't breathe. It is horrible to go through that. So that little tiny bit of Roxanol will smooth out that muscle, help us relax, and help the patient catch a breath. It is like magic. It is not going to kill you. In fact, the amount of Roxanol that we leave in a patient's home might do damage to a child or a dog, but not to us. So please don't, and if you ever want to dive into that further, ask a nurse. You have one here locally. It is not going to hurt anybody. And again, that's just one of the many medications that we use for symptoms that are associated with end of life pain, anxiety, again, breathing issues. We have other drugs that we use for nausea that are really helpful, and anti-anxiety medications as well that also serve as anti-nausea medications. So there are things that we have in our toolkit that are specialized. Again, hospice and palliative care is a specialized form of medicine. All of our physicians are certified hospice and palliative care physicians, and that is not like that everywhere else. So we use our medications with great confidence, and we direct our nurses, well, I shouldn't say we, but they, the physicians, direct the nurses with great confidence. This is the only type of medicine that we practice, and we are specialists in it. And I promise you, we are not going to shorten anybody's life from using medication. That is a wives' tale.
I have a question.
Please.
What can you expect in the way of how morphine affects a patient's mental state, or is that dependent on the dosage?
That is dependent on the individual patient. There are people that are sensitive to certain types of medications, and that's across the board. I mean, from Tylenol all the way on up. So everybody is going to be sensitive in their own way or not. There are people that are incredibly allergic to certain medications. We, of course, need to know that going in if there is a reported allergy, and we will adjust as needed. So people, their mentation, you also have to realize too, that especially when we are moving into end of life, changes in mentation are normal. And we see that increase as we get closer to the end of life. So that's a whole nother presentation that I do about the end of life process. So
Lots of old folks are, have not had a lot of narcotics in their lives. We call them narcotic naive. But the motto that we used as nurses was start low and go slow.
that's right.
So, yeah.
Very true. That's true.
Yeah, unfortunately, my mom was 96, so she was quite old, and when she was on hospice care, she was having some difficulty breathing. I wasn't with her, I was at work. And so they called and said they were going to give her a little bit of morphine, and they did. And from that point on, she never woke up. So as I came out to see her, left work over there. And I mean, she stayed alive for another 2 days, but the morphine they gave her basically, and they said that she's probably getting ready to go. And when she got that relaxation, it was probably her wish to just start that process. Like the body was saying, I can relax now, I can now do that. Have you experienced that?
All the time. And one thing I will say, and I'm going to defer to my resident nurse expert, but morphine itself has a very short half-life. Probably one of the shortest, meaning it metabolizes through the body quickly. So that's why, as a patient, if there is a patient that is symptomatic and a lot of families are like, what do you mean every hour? Because it goes in and it's quickly metabolized in the body. So it leaves the body very quickly. So for a patient that is experiencing extreme symptoms, whether it be pain or breathing challenges, it is indicated to keep dosing that patient to make sure that we don't get into another, trouble zone. But to answer that question, yes, we do see that. We do see that. But keeping in mind that that dose of morphine exited, pretty quickly, usually within an hour, it's metabolized from what I understand. Is that right?
Well, and when my mom was in the hospital and started hospice care, of course, I was asking questions. At our hospice facility, nurses were able to have a range, like 5 to 15 milligrams was our range for a patient. And we could give the lower dose if we wanted, or we were trained enough that they trusted us to make a call if more was needed without having to call the doctor. In the hospital, that was not the experience. And the other thing was the nurse didn't know how to give it sublingually the way we did. I showed her how it's like, we do this all the time. Let me show you. So it's just,
It could be some variance.
yeah, there's a difference between typical hospital nursing. And I don't know about at a assisted living or skilled nursing. I don't know how much those medicine givers are trusted to have a range, So that would be something to ask, you know, can you look at the patient and decide they can have a low dose now? Oh, no, they're really hurting. I'll go to the upper
Right.
limit of the range. So,
And if that was the first episode that she had.
yeah,
Anyway,
yeah.
I just, I didn't want to prolong
Yeah.
that, but
That's
yes. thank
Next
you
slide,
for that.
please. Okay, hospice is all about hope, and that is a fact. And so again, here we are trying to demystify that word, but we want to talk about hope, and that hope changes when we have a life-limiting illness. You know, we don't look at it in fractions of time. Now we look at right now, the day. I have hope that this is going to be a good day. I have hope that we're all going to be able to gather like this moving forward through the winter, because this is so nice after this pandemic. This gives me hope, you know, right now at this moment, this moment that is all that is real, right? Not to get too carried away on my airy fairy bandwagon, but this is it right now in this room. And this is what's the good stuff is right now. So it really, we want to reframe that when you are diagnosed with an illness that is life limiting. We want to have hope for today. Yeah, we want to think that tomorrow's going to be a hopeful day too, pain-free, that we have laughs, that we are with our loved ones, that we are inspired. And again, in a place like this, where we can gather together in a beautiful place of worship and deepen our connections to one another, which is the stuff that really matters, right? And so it's just a shift. It's a shift in the concept of our medical treatment and focus, right? And it is a shift in our consciousness. So we are looking at this moment as being as good as it can be. So right now, that's what we're talking about, that hope is real in this moment for hospice. And it's very important to stay rooted to that. We do want to say that we have a lot of studies about hospice and the outcomes. And I do want to just quickly touch on that. Lots of people would benefit from this service that don't get the service because of these misconceptions out there. And so we just want to talk about a couple of things, miracles occurring. Okay, about 3 to 5% of hospice patients are discharged back to their physicians. Will no longer meet the criteria, and they go back and we can readdress their care when needed. But that's a pretty large amount of people. When you look at all of the folks that are served, 3 to 5% get discharged or booted out of our care lovingly. We hand them back to their physicians, or we'll help them find one that visits if they need a visiting physician. And a clinical study, this one that was based on about 4,500 terminally ill patients, indicated that hospice patients lived an average of 29 days longer than the patients that were not on service, hospice service. And that's pretty incredible. There was another one that was published in the New England Journal of Medicine, found that lung cancer patients that received early palliative care lived 23% longer than those who did not get that care. So there is hope. And you know, this form of care, we want to make sure that everybody knows that. We want to move on to the next slide. This is a quote from Dame Cicely Saunders. She was pretty much, she's regarded as our founder of hospice care as we know it now. Dame Cicely was actually the entire what we call interdisciplinary team in one person. She was born in England, I think around 1914, and began practicing as a nurse in the 40s. She went on to get her social work degree. She got her master's in social work and ultimately went on to become a physician and became what we now know is the founding mother of hospice. Now, first hospice in London. Matter because you are you and you matter to the end of your life. And so this quote is true. And we will do all we can to help people die peacefully and to live until they die, not to sit in a place of waiting and dread, but that is real. And Dame Cicely really, you know, personified that. And she is was an incredible person and wrote a lot of great books. So if you want to ever look into her, it's great research. You can actually take a tour of St. Christopher's if you go to London. I don't know, it's an interesting stop. And again, she was pretty much the foremother of what we do. And again, this is one of our 888 numbers, 992 care. And anybody can call that. And again, I am available. And if anybody wants to reach out directly, they are welcome to do so. And again, my name is Julie Capra. I am your local advisor here at Arbor, and I welcome your questions and calls and
Okay.
emails.
I'm gonna stop sharing. If that's okay.
Hi again, everybody. Sorry you were so small. I couldn't see you raising. I apologize. Does anybody have any other questions? Yes.
I have a comment. My husband was in hospice the last 6 weeks of his life at Chelsea at the Towsley Center, and he received very good care. He was placed in hospice because he was taken to the hospital each time he had a seizure, and it wasn't helpful. And after he was in hospice, that no longer happened. After he died, a friend of mine gave me a hospice heart. And I didn't hear you mention that, but I'm now a part of the group that does the embroidery to prepare those hearts, and they are available to give as remembrances to people who have lost a person. And I just wanted to say that for me, that's been an important part of my grieving process.
Well, thank you so much for mentioning that. Yes, the Hearts of Remembrance is a long time. I mean, that goes back to the beginning of Arbor Hospice in 1984. So we have so many folks in this community that are part of the sewing circle, if you will. And yeah, that is a beautiful, beautiful thing to have. And we have a different, I think it's every year, isn't it? That we have a different design, and we have multiple designs now. We always have a veterans design. And so they're beautiful, and all of the proceeds go to our various foundation buckets to help provide the services that we do, like grief support and other items. One thing I want to mention about another item that we offer as a non-for-profit, and this is something that's really important. After we affiliated with Hospice of Michigan 5 years ago, they were a competing non-for-profit, and we essentially got married. And now we're in 16 clinical locations across the lower peninsula. So if you go up to Alpena or Traverse City, we have care teams in all of these places. Grand Rapids, we're much larger and stronger together. We kept our name Arbor Hospice, even though we are affiliated with Hospice of Michigan, because we are a legacy agency too. Really grateful for that. But the another program that we have that is incredibly helpful, it's the Quality of Life program. In addition to the Hearts of Remembrance, we want to mention some of the buckets that this money goes to. But Quality of Life helps people in tough situations. We had a patient recently that we were able to buy a furnace for because hers went out. And so we actually took the funds from Quality of Life and got her furnace fixed and bought the equipment needed to take care of that. So she was able to maintain her independence and stay at home. Another patient wanted to go to Traverse City, and she didn't have the funds. She had depleted all of her funds over her long battle with her illness. So she and her daughter got to go to Traverse City one last time and see Lake Michigan, and that was on us. And so these are things to me that are so meaningful, along with those, as a way to remember and a way to give back. That make it a really special place. And again, I'm fiercely proud to work for this organization, and thank you all for having me.
Well, thank you so much for coming. We appreciate it. And I'm a member of hospice at this point, and everything you've said and a lot more I've experienced, and it's a quality operation. It really is. And that number that you call, the 992, will get you almost anybody. I can get you through it. I can get a doctor through it. I can get a nurse. And in cases where we've had difficulties, middle of the night, you can call, and they'll direct you to somebody that'll fix you. And as opposed to getting in a car or an ambulance, going to a emergency facility and finding out that you don't even get looked at for 6 hours.
Mhm.
And it's right in the home. They'll come out. We had a problem that needed to be taken care of. We called, and within an hour and a half, a doctor and a nurse, middle of the night now, we're out there fixing it. And that doesn't happen in the normal system.
That's true.
So, yeah, there was a term you gave me that, what was it called? Comfort versus torment.
Versus curative.
Say it again.
Comfort versus curative.
Okay, comfort versus curative. Curative sometimes is torture, so.
It can be if you know, it's not always curative. It's just
Yeah.
sometimes what they.
Great. Well, thank you very much. And I think I and most of us would like to hear those other talks that you have because it's very interesting.
Very good. Thank you.
Anne, would you hold up that heart again one more time so I can see it? Oh, that's lovely.
And as she said, the design does change each year. So this was the 2020. This was one I got for my mother back in 2011.
Oh, that's very nice. Very nice.
And right out.
I just wanted to give another shout out. Anne, I didn't realize you made Hearts of Remembrance, but I know a couple other people from our church who do. Lynn White has been doing it for a long time. I think Alice Nuttall also does, and Anne, you may know other people.
Amy Jo Herndon is the new co-chair of the group. I see Amy Jo and Lynn at the monthly meetings.
Well, I received several Hearts of Remembrance from one of the family members of one of the people I was seeing, and he was so appreciative. And I haven't got my Christmas stuff out yet, but every year I put it on the Christmas tree. Well, I guess I'm not having a Christmas tree this year, but I'll get it out. They're really special.
Thank you, Julie and Bob, for bringing us
Thank you,
together.
Julie.
It's been just excellent.
Yes.
So much
Yes.
appreciated.
Yes.
And thank you, Debbie and Amy, for your support.
This will be available on
Yeah, I'm just,
YouTube.
right, I'm stopping the recording right now.